Fibroids or leiomyomas are composed of interleaved bundles of smooth muscles and connective tissue. They're the most common pelvic tumor. They increase in prevalence with age. 20% of women greater than 30 years of age will have pelvic pain, will have fibroids. It's more common in the black population than in the white population. Fibroids are usually multiple of various size and seen mostly in the body, in the fundus of the uterus. This is the indication for 30% of the hysterectomies in the United States. Classifications of fibroids include intramural, submucosa, and subserosa. Intramural are fibroids which are confined within the myometrium. This is a nice drawing on the right from Dr. Netter's book. Submucosa fibroids are those that are projecting into the uterine cavity. And when the whole submucosa fibroid is within the endometrial cavity, it's referred as intracavitary fibroid. Subserosa fibroids are those that are projecting from the peritoneal surface, and when the whole fibroid is projected outside of the uterus with a pedicle, they're considered pedunculated fibroids. Leiomyomas or fibroids clinically the clinical presentation of fibroids are variable. They depend on the size, the number of tumors, age of patient, proximity of the tumor to the endometrial cavity, mobility of the fibroid, and the presence of degenerative process and infection. Pain is usually due to degeneration, infarction, and infection in the fibroid. Strong uterine contractions, rotation of the fibroids within the pseudocapsule may interfere vessels and result in necrosis. Torsion of pedicles may occur in the subserosal and submucosal fibroids and can cause infarction, degeneration, necrosis, and potential infection. 5 to 10% of the fibroids are submucosal. They encroach and distort the endometrium, causing abnormal bleeding. These submucosal fibroids are prone to necrosis due to insufficient blood supply. They're also prone to infection, exposed position predisposing to ascending infection. And also they're prone to degeneration, which is due to the torsion of the pedicle. All these can cause pain. Intramural fibroids most commonly cause uterine enlargement. They can cause pain when they necrose, degenerate, and less likely get infected. Subserosal fibroids cause pressure on the adjacent pelvic organs or ligaments, causing pain. Leiomyomas are estrogen dependent, usually regress after menopause, and increase in size with pregnancy. In postmenopausal women, if a leiomyoma increases in size, it needs to be removed because of the fear that there may be sarcomatose changes. Leiomyomas the sonographic findings of leiomyoma is variable. They may present as a uterine enlargement, they may be mild to moderately echogenic mass, causing nodularity of the contour. They may cause distortion of the endometrial echo or alter echo of the myometrium. They may present as a hypoechoic solid mass with poor posterior transmission, or increased echogenicity, and that may be related to the fibrous component, or if it's associated with posterior acoustic shadowing, it may be due to calcifications within the fibroid. 25% of the fibroids will have calcifications. Some of them may be small, others may be a rim around the fibroid. A hypopseudocapsule can occasionally be seen, and occasionally cystic degeneration seen as irregular anechoic areas may be present. Here is a transvaginal view, sagittal projection of the uterus. Midline, we see the endometrial cavity, and you see the endometrial mucosa being displaced by this heterogeneous mass, which has posterior acoustic shadowing. Here is a transverse view of the same patient, and you can see nicely a hypoechoic or heterogeneous mass with shadowing, displacing the endometrial cavity. This is an image, a 3D acquisition coronal image showing an intracavitary fibroid. We can see nicely the endometrial cavity surrounding the fibroid. 2D coronal view obtained from a 3D acquisition is very helpful in being able to identify the location of these submucosal or intracavity fibroids. Here's another patient, longitudinal view of the uterus, midsection, and we can see longitudinal and transverse. There's an echogenic mass in the fundus of the uterus, and this is a fibroid that probably has fibrous changes, very echogenic. Here's another case. It's an older case, but it shows how sometimes these fibroids can obliterate visualization of the endometrial cavity. And here you see all these echogenic masses with posterior acoustic shadowing, and which prevents us from evaluating the endometrium. Fluid within the endometrium can be very helpful in outlining the submucosal fibroid. Here on your left, we have a transvaginal study with a small amount of fluid secondary to a sonohistogram that was done, and we see nicely a broad base hypoechoic mass, which is being outlined by this echogenic linear structure, which represents the endometrial lining. This is a submucosal fibroid. MRI can be very helpful in these patients. There's probably no need to do an MRI in most of the cases because the diagnosis can be done with transvaginal ultrasound and sonohistogram and the 2D coronal image that we can obtain with 3D acquisition. But in this case, you can see MRI view showing nicely a little fibroid displacing the endometrial cavity. And this is a nice way also to see the relationship between the fibroid and the endometrial cavity. Here's another MRI, coronal and axial view showing the uterus, axial view of the uterus with the endometrium. And here was a mass, pedunculated fibroid, which this MRI image shows nicely the relationship of the fibroid to the uterus. The management of symptomatic fibroids is various. It can be medical, hysterectomy, a myomectomy, hysteroscopic procedures such as endometrial ablation, especially in submucosal fibroids that are causing bleeding, or more recently, uterine artery embolization has been shown to be very helpful in patients who have symptomatic fibroids. Uterine artery embolization causes 50 to 60% of these fibroids to reduce in size. It can relieve symptoms in 85 to 95% of patients. It causes shorter hospital days and a rapid recovery time. And here we have another patient. On the left is a transabdominal study showing a longitudinal view of the uterus. Endometrial cavity is being displaced anterior by this heterogeneous hypoechoic, predominantly hypoechoic mass. Transvaginal ultrasound, you can see the mass better, that it is heterogeneous, and this was a fibroid. This was a postmenopausal woman who had a fibroid. She returned 6 months later because the uterus had increased in size, and as you can see in this picture, that the fibroid has almost doubled in size. Any postmenopausal woman who presents with increasing in size of a fibroid needs to have it surgically removed. And the reason for that is because there's always the potential of uterine sarcoma. Uterine sarcomas arise from the mesenchymal tissue. Less than 2% of them arise from existing fibroids. 85% have irregular bleeding and 19% present with pelvic pain. An enlarging fibroid in a postmenopausal woman should be treated with suspicion. Usually the diagnosis is not done preoperative, since sonographic findings are very similar to benign fibroids. The extent of disease in these patients is very important because it determines the prognosis. When a cancer is confined to the uterus, the 5-year survival can be up to 50%. Here's another patient, a transabdominal study showing it very difficult to see the uterus, and there was very heterogeneous with echogenic linear structures and shadowing. Here's a CT showing that a lot of this echogenic structures, linear structures that were seen on transabdominal ultrasound were actually gas within this mass. And what this was a necrotic uterine sarcoma.